Two vascular surgeons walk into a bar and come out with a podcast. We are talking everything vascular and not. Welcome to the Life of Flow podcast.
The following podcast is not relating to my teachings and work at Del Cedar Medical Center and is for entertainment purposes only.
Welcome to another episode of The Life of Flow. Today we are at the Link series. This is a series of 6 shows we did during the Leipzig interventional course, where I initially did some training many years ago.
I think we did 5.
Doesn't matter.
Okay, keep going.
Okay. Anyway, y'all, we had a great time and we invited a few phenomenal people. And today the episode is about Maria Antonella Ruffino. Maria Antonella is an interventional radiologist who heads the interventional radiology unit at EOC Lugano in Switzerland. Honestly, just a fun conversation, a little bit about who she is, her training, her mentorships, what training is like now. And we really kind of went into some of the topics that she presented at here at Link. So I hope you enjoy it. A lot about ALI and clot removal and stuff like that. So I think it's a goodie.
Vamos.
Stick around. Such a pleasure to have you today with us, Antonella. We met in Latin America. Yeah, and it was through an EndoLat meeting. Of course, that we had met at different meetings before, but I had never really had a chance to hang with her. I always call it our meeting family because it's the same people. I've said this joke before. My wife says, so when you go to these meetings, it's basically the same people talking about the same things all again. And I say, this is exactly what we do. And we just go to all different countries and we all get up and we say the same things in the different meetings. So it evolves, of course, but it's so, it was very refreshing to meet you. Very creative, great hands. I've seen your cases and it's always been great. So I appreciate you carving a little bit of time. We're here at Link in Germany, and so we appreciate your time. Thanks for coming and talking to us.
Thank you for having me here today.
Thank you so much.
So I think one of the things that we like doing whenever it's a first timer, meaning we would really like to talk with you more in the future as we have more shows. But, for our listeners and certainly for us, I don't necessarily know the details of your background. And I think it's always very interesting how people end up in this particular area of vascular interventions and the peripheral vascular interventions. So if you don't mind, take us back however long that has to be. Was it like in high school? Was it in college? Was it later in your career? When did you start understanding that this was possibly going to be your path?
Actually, it happened by chance in the beginning, of course, because I wanted to be a surgeon. So I was attending in a department of general surgery, and I was focused mainly on pancreas surgeries. But at that time, most of the patients were referred to the interventional radiology department for having a biliary drainage, and it's how I get in contact with interventional procedure under XR guidance, and that's how it started. So I saw the passion of my colleagues, my radiologist colleague at that time, and I said it was amazing. It was something completely new. It was not standard surgery. It was a different approach. It was fast. It was a good solution for suffering patients, and I was amazed by that. And also the guy were aware of new technology, and it's opened up to me a completely different world. And that's how it triggered me, and I decided to move from surgery to radiology. So I did my study in diagnostic imaging, of course.
So how far into surgery were you already?
Just before to start the post-graduation course. So just after medical school, last year of medical school.
Oh, okay. So you were thinking of starting a residency,
Surgery.
But you hadn't started officially.
No.
And this was
because
changing.
in Italy you can attend the department because you need it to get take your exam.
Yeah.
And so that it's working. You need to spend a certain amount of hours in the department, the university hospital. And so that's how it happened to me. So I started I asked for we call it a thesis for a topic for my my graduation in medical school. And I started with biliary drainage in transplant, hepatic transplantation, liver transplantation. And so that's how I started. I started the post-graduation course in radiology. I spent 3 years doing mainly non-vascular intervention. And then the last year, I spent 1 year in the vascular radiology department. And there was the department that hired me at the end of my post-graduation course. At the time, endovascular procedure in Italy were not performed by vascular surgeon because it was everything in the hands of the interventional radiologist. My chief at that time was really a pioneer in that, and he's got so much passion in what he was doing that he was able to transfer the same passion to me, at least, and also to my colleague, me in particular. And it was amazing work with him, and that's how it started. And I'm still, I was very lucky because at the time was still accessible, yes, for interventional radiology to big procedure like EVAR and complex cases. And I still can do that because I'm not that young, so I'm still involved with that. And most probably is not longer possible for the new student, the new guys that are approaching interventional radiology anymore. Most probably is not even of interest for them because the interventional radiology is offering so many different procedures for different pathologies, different district of the body. So you can do really many other different things now. And so vascular is a small field and going to disappear most probably. But I'm still in love of my job.
But you did it all, like you were doing interventional everything first and as your training. At what point did you say the blood vessels is what I love and I'm going to get into this thing? Do you remember how that came about?
It came also because of different kind of patients. So oncology procedure that are related to suffering end-of-life patients. There is something that is also difficult to bear. Not that vascular patient, they are luckier than this because they lose legs, but you have an options to leave most of the procedure performance, a non-vascular procedure that I was doing. That's in the liver and kidney and gastric part. It was for end-of-life patients.
Okay.
And it was also a big way to see those people suffering with not many chance for surviving. And vascular was something that you can really give something back to your patient. So a patient that it was claudicant, you can see walking again. A patient that's got a wound can heal and start living better again. So you really see that you can change something. Not that you cannot change an oncology patient, of course, but it's different. It's a different story, different pathologies. And that was nice. It was something that really gave me immediately something back.
You were mentioning a mentor, somebody in your division that was very strong. Who's this person that was very strong? And maybe tell us a story that you remember that would showcase why he was so strong.
I always mention him. It's always joke of that. It was actually the chief of the vascular interventional department.
What was his name?
Claudio Rabbia.
Claudio Rabbia.
He was really a pioneer, at least in Italy, but he was well known.
He still practices, or he's
in private practice?
He's still in private practice.
Yes, he's retired. And I remember that I cried when he left. I was feeling abandoned. And but he started as a general radiologist, so doing a report for chest X-ray, everything, and then he was involved in duplex ultrasound. And so starting by this, and then always be update on new topic, new devices. And he started also the interventional procedures. And at that time, everything was so complicated. There was no technology. And when we have the first balloon for below the knee was actually something that really changed everything. Most of the time we were...
What year was that? Do you remember? Around
2000?
What time? Around 2000, the first below the knee balloon?
Yes.
Wow.
Yeah, because
I dedicated. Right?
Dedicated, yes.
Before
it was so
we
coronary.
were talking to Roberto earlier, and he was saying that he was doing procedures before, but with a 2-centimeter balloon, and you'd have to inflate it 30 times in a
30
tibial.
times. Yeah, I know. That sounds crazy.
Yeah. And
I mean, it was an Italian, right? It was Invatec. It's probably one of the first companies that came to the market with actually long balloons, the famous Amphitryon Deep.
the Pacific.
Pacific.
So it was really the beginning of a whole world opening in front of us. And it was nice to see, because I had the opportunity to see the old jaw stand that you still need to crimp on the balloon. So I didn't see the Dos Santos, luckily, but they said that I'm younger than that. But I've seen the evolution of these technologies, and it was amazing to see what you can do. That is actually something that helps you also to think a little bit outside of the box, because now you have all the technology that can help you a lot, but at that time there was nothing. So you have to think about how I can do to make it happen, to make it possible. And so it was amazing to always to discover something new that could be helpful for the patient, for the
Any
treatment.
moment that you can recall where you like did something or came up with something really creative to solve a particular problem?
There was always something that I still remember. Now we talk a lot about this kind of repunction of balloon and with a re-entry system. At the time, everything was. I still remember the tips needle that we use off label, of course, and that we would try always to find a solution. And now we have everything is really straightforward. You use this, you use that. At that time, there was nothing. So that use this with that, and then we do the opposite. And so it was always was nice. And so
it seems like it's a very common factor that unites us all, that we are very, all of us in this world, I think, because of where it's at in its evolution, we're all incredibly like creative, like very, very curious and trying to figure things out, right? It's fun when life, I guess, in a way, it's a puzzle, because every day you come to work, and that's what for me was very entertaining about vascular, as opposed to some other. Like I remember in cardiac surgery doing a rotation, and I was like, this seems so boring.
Just 3 surgeries.
Like we're just taking out this valve and replacing the valve. And of course now it's changed, and I'm being very unfair to anybody that does cardiac surgery out there. I respect you, a lot. But at the time I just felt this seems like the area where I'm going to have a lot of fun figuring shit out.
Yeah.
Like there's a lot to figure out, and there's going to be technology coming. And so it is. Like every day there's something new. Every day there's something different that we use to do that. Did you ever let your mentor down? Did you ever remember doing something that he got really pissed at you?
Most of the time it was pissed. That's the only way that you learn.
Yeah.
Now it's something that is not allowed anymore. You cannot do what they have done to us. Of course, at least.
Yeah. Do you know the heartwarming message that Miguel sent me on my graduation day? He sent me a picture of a groin hematoma, and it's like, look at what you did to my fucking to my patient as I was like graduating. I was like, oh, he still loves me.
Well, that's true. That's your problem. I told you to hold pressure and check it with ultrasound, and you probably didn't, do what I told you. But it's funny how these are. It's almost like bittersweet relationships with your mentors, where they don't even have to be that mean, because if you let them down, it's like the worst.
Yeah.
Like if they don't say anything, I remember like Andre. So Andre Schmidt was one of the guys that trained me, and I remember if I would like screw up, he wouldn't say anything, but he would just get very quiet. If he was quiet, I was in trouble.
Yeah.
And I remember just like feeling so bad that like I did something wrong.
Yeah.
And then like for the entire rest of the week, I was like trying my best to make him happy again.
Yeah.
Nothing changed it. Like it was like days where he wouldn't do that. But that's how it is.
It's like so much psychological trauma in such a small amount of time.
And I remember that it was super fast. So he did not wanted to, but he would love if you can prevent what he was doing next. So you were be always ready to give him what he needed in that moment of the procedure. And it was like a challenge, to be always ready to give what you and read in his mind. Because if you could read in his mind, that means that you were learning, because you were knowing at a certain point the next step, and that it was nice. That it was really the goal. I will be as fast as you. At least in my mind, you are doing that, but I know what you wanted to, and it's actually an achievement
Are you
for me.
teaching at the moment? Do you teach fellows or residents?
I do teach, yes. I am at the University of Turin in the post-graduation course for vascular intervention, of course, and also at the University of Southern Switzerland. I have some in the circulation topic. I have some student there as well. I like it, but I found out that the education is different from my education at that time. So now you need they are more demanding. Why for us? Well, for us it was not possible to ask. It was coming from above everything, and it was like this. So I cannot say that I learned a lot from my mentor, but I cannot say he said to me the correct way of doing something. He was looking at him doing all the step of a procedure that I learn a way of working. But it's not that he was saying, now you have to do this, and then the next step is this one, say it again, something like that. And now I see that from the student, they wanted to be following in every and each step of one procedure. If you don't give them that, or maybe they made them too spoiled, I don't know if it's something that we can say, but at least the way of learning and way of teaching is absolutely different than from
Very
20 years
different.
ago.
Very different. Very
They have
different.
different expectation from you. They most probably is better like this, because I remember I've spent most of my days until 9 o'clock in the department, and it was not nice. But now they want to set also the border, but now and then to have this everything with less than everything back. I don't know if I'm
Yeah.
myself understood.
The relationship's not equal. Like the give and take is not equal.
When also
Yeah.
they want everything so structured. There's almost like you owe them to teach them, and it almost like they expect you to give them this structure, very processed. And I guess being critical to me or to us is that the specialty is becoming a little bit more structured. Like before, when I started, like there wasn't like a structure on how to cross a CTO, or there wasn't a structure on how to do a carotid stenting. And so there was a lot of that learning that was just by seeing operators and seeing people operate. And then you'd have to come home and think about how you would do it. It's almost
Yeah.
like you see one from multiple people and then you figure it out. But I guess today, like it's a little bit more. I know we're ages still away from being consensus based
Yeah.
at
I
all
think we're
levels
really far.
or database,
Yeah.
but it's still a little bit better than what it was 20 years ago,
Probably.
right? And so these kids probably come with an expectation that we're going to teach them the right way from the bat, and I don't know, it's different, but it definitely I learned much more like you, where they weren't giving me structure, and I
Yeah.
just had to pick up things
And observe. Yeah.
as they were coming.
Kind of make a mental model in your mind and then apply it. That I still think it's probably a great exercise to do, because I feel like if you don't think about it, like if you could just go like an automaton and somebody tells you, okay, now you push the wire here, now you push the catheter here. I don't know how much you integrate that, until you have to actually think yourself, okay, where's the wire going to go? Where do I want it to go? How do I want it to move? I think that in that way, you kind of integrate that learning in a more permanent way than if you're just basically a mannequin being
Yeah.
driven by my words, I don't know.
It's really different, and I'm not sure is that the way that can achieve more than what we learn, because I tell you all the step, but then it's difficult for you to, because it's not something that you need to remember as a song. It's something that you
Correct.
need to adapt. So even I tell you each and every step, it's not that you need to do that, but you need to understand what is needed and what need to be changed to
Yeah.
this routine or this way of doing that. And only if you watch other people working, I think that you can find a way that can be adapted to all the case and all the situation, and also the bad moment of a procedure, because it's not always straightforward that we achieve a goal and everything will be fine. So you need to be ready also for complication. And also one thing that I don't see in their eyes is such
The
good
fire.
good fear,
Mm.
the good fear, the alarm. So you know it can be bad. You're taking long in a iliac revascularization. Mm, Be fast, do the proper stuff. Don't wait too much. If you have some doubt, check. Don't spend too much time in a tricky situation. So the good fear that alarm you, and so that is something that I don't see very often.
The healthy fear
There
and
might be
healthy capacity to pivot.
unawareness that you are in a tricky situation. It might be, I think understanding the consequences of things, you get to that point when you have a complication, when something, or when you have to fix something on the fly, then you understand urgency. Yeah.
It's like in carotid intervention, and if you
Mm.
make it longer with a filter, then do it without a filter. I know you have to balance your skills and the time that you are spending in a procedure, and find your way of working, and make it proper. It's not that it's necessarily mine, and so if I teach you my steps, might not work in your hands, and the opposite.
Hello, everyone. My name is Lucas Ferrer from the Life of Flow podcast. We are here today to invite you to a very special thing that we're doing here. We're giving back to the community here at Life of Flow. We're involved with Austin Sunshine Summer Camps, which is an organization that's been in Austin for more than 50 years, providing free summer camp to underprivileged kids who wouldn't be able to afford it. Most of these kids' families' incomes is less than $30,000 a year. So we're trying to get enough funds this year to get 500 kids locally to be able to have that experience. And we're calling on our audience to help us achieve this.
That's right, Lucas. Austin Sunshine Camp is really an investment in our kids that will re-up countless dividends for you in your soul and in your emotions and your heart. You are affecting real change and really makes a difference. So here's the deal. Lucas set the account. It actually started rolling already. There's over $1,000. So thank you to everybody that already participated. And we're going to invite all of you that have not to just consider giving a little bit of the fluff you may have. We wanted to see which company out there was the most philanthropic, full of the most philanthropic people. So here's the deal. You may put your name if you feel like it, but if not, at least put you work for company X. So if you work for Boston Scientific, you work for Cook, you work for whatever company that is, you place it where the name goes. And so then we're going to tally. So literally tell all your network of people within the company to help you viralize it, because guess what? We're going to have a show dedicated to you, to the people within that company, and we'll throw some ad rolls in there for your marketing company. I mean, our little way of saying thank you to anybody that wants to help us with this project, right, Lucas?
Right. Really appreciate all of your support. We'll give you an update, how much money we raised to really allow these kids to have a wonderful summer. So thank you so much to everyone.
Pura vida.
Vamos.
Let's pivot a little bit to some of the topics that we have had here in the meeting. I was I was very happy to join in a panel yesterday where we were talking about management of clot, which I feel has exploded in the last few years. It seems like every time you turn around, there's a new thrombectomy device coming on, or a new startup that has a new thrombectomy for some different indication. And I will say that being that we've been in this enough, And I come from when there was no thrombectomies, where the only thing that I would do was put a guiding catheter in a 60 ml syringe. That's it. That's my thrombectomy catheter. That's the Costa Rican thrombectomy catheter, man.
Also Italian.
And you just put the guiding catheter, you put it, and you suck that thing, and you just pull it out, and then hope that it comes. And then the first iterations, I also wasn't very impressed with how they were working, and so I just felt this is a super expensive Costa Rican guiding catheter stuck to a machine.
Yeah.
But then things
hook it to wall
started
suction.
evolving. It seemed like these algorithms of suction, what they're calling like intelligent sucking machine or whatever they want to call it, started evolving. And I've seen myself starting now to adapt, not only on these sort of catheters, but also maybe some of the dragging catheters, distal, where you put a basket and you drag, or some frontal where they suck, or some are just kind of cutters that macerate. And you actually presented a super cool case of a distal bypass that went down. She opened it and it looked beautiful. But what has been your experience in this
What did
world?
you use
tell us about the
yeah.
case, what you did in this case, and then maybe that could be a good introduction to the topic.
Yes, it was a distal bypass. Actually, very great work from the vascular surgeon. It was a distal bypass popliteal on the distal perimalleolar posterior tibial artery, and it was occluded, and the patient had a Rutherford 2A. And actually, we decided to A. Actually, you could also wait, but there was a bypass occlusion in a very distal, so we wanted to save it as soon as possible and not make it longer anymore. Any other complication did that. And so we decided we go for thromboaspiration. And I have to confess that I always be a little bit aggressive with this kind of aspiration system. So I loved them since the beginning, and I made them do really weird things, but it was working, and the good result support me in the idea that I should do it as any time it was possible. And some can look at me. There was in the end it was a venous bypass, but it was very small, and actually I use a 7 French that you can say, right, you go tibial and you take something big. It was a vein, so in the beginning it was big,
if it's
but
a
different.
penumbra, it's only like 2.3 millimeters, so it's not that big actually.
No, it's not that big, but people
Maybe she
think
put it all the
that-
way to the ankle, so I could
I've
see
done-
somebody.
I've done that.
You too. I could see
too.
somebody being
Yeah.
a little bit nervous about doing it. But tell us about that
Yeah.
experience. I mean,
Yeah, I do not mind to go this also because with something smaller, it's really
It's not
difficult.
gonna do
that
anything.
I use a 6 when I go on dorsalis pedis on plantar arch because the 3 is really
Yeah.
super small, and the 6 was a balance, but with the 7 is is a 0.3 millimeter more, and you can achieve a lot of aspiration. And I did with VI. I confess I also use the Cat D from FemPop because I have a shorter dead space. So I can my mind, I think that I can aspire more than
Mhm.
a long tube. So there are some modification that I've done, but I do not mind to go with a 7 distally. And actually was the result was good. We have a fibrosis distally of the vein. Of course, it was treated with balloon, but the result was really amazing. I'm always amazed, and I like acute limb ischemia. There's something bad to say, of course, that I like acute limb ischemia, but I like
you like the
working in that field.
challenge.
Yeah,
It's a challenge.
yes,
Well, it's the only thing that exactly is one of the few things in peripheral where it's still quite a challenge. I think now it's becoming less of a challenge with all the new devices, but still, I think there's some interesting questions. Do you ever do TPA up front for these?
TPA. Very, very few cases. Also because I come in Italy, it was possible to start thrombolysis and keep the patient in the ward.
Yeah.
In Switzerland, it's not possible. You need to send the patient in ICU.
Yeah.
It's always like US, Switzerland. So
Yeah.
getting more expensive and longer procedure. And I have to say that in my opinion, thrombolysis is really a miserable time for the patient, because the pain is not managed by anesthesiologists. It's really make you crazy, I think. And so that I don't like anymore. In the beginning, the only thing that we had in the beginning were the center in Italy was one of the first to try with Rotarex. Beginning when it was still Straub, and we use it at the time only for the bulking, and then distally with lysis. And now it's no longer needed, because with the same platform you can go really distally, and it makes sense to solve the problem as fast as possible for the patient. And
So what is your algorithm? If we can break it up. Now I want to be one of the students where I want you to tell me everything.
We'll go around the table. Start with yours. What's your algorithm first, and then we'll go around the table. For, say, tibial SFAs, all filled with clot.
Okay, so I think it just depends a little bit on the nature of the beast. Where is the territory that I'm trying to attack? How distal it is. If I am in the femoral popliteal segment, I still think that using Rotarex is a very easy way to clear, and I've had really good results. So I haven't really adapted, and I can do it through a 6 French. But let's maybe do that. Let's start with like a fempop segment. I would say Rotarex 6 French is my first option, and I would say the second option is I've come to like, because Lucas insisted that I should give it a shot because I hated it. But the Bolt 7 by Penumbra actually has a pretty interesting capacity with this, and so it seems like it's working much better. And so, but it still, in my opinion, does not dethrone the capacity of the Rotarex to do really good cleanup of let's say a fempop bypass or an SFA stent that goes down. What about you?
Well, first I always check. I don't work by myself. I have also vascular surgeon. I'm an interventional radiologist, so vascular surgeon are always there to help support, and so we discuss everything together. If it's not embolic, it's thrombotic, and it's fresh, I go straight forward to aspiration. If it's long, the symptoms are longer.
Which device do you like for that?
For aspiration, Penumbra.
A Penumbra. Do you go with like a 7 one or a 6, or which one do you?
7 or 6. 6 is not longer my workhorse. Let's say it is 7.
Yeah.
And for iliac I use a 12. I've used a 12. Now I use the 2.0, the flash for iliac, because whenever I could do it also with a pre-implant of 2 percloso, so I can do it also with a percutaneous approach. But anyway, if it's fresh, the symptoms are less than 2 weeks, then I go straight forward to aspiration. If it's longer, then Rotarex is still my option. The only thing that Rotarex, you have that channel, and that's it. So you need to improve it. It's a 6 or it's 8 French, or maybe something more, according to what device do you use, and then you still need to work a bit on that. Post-dilation, stanting, or something like that. If you're lucky, with aspiration, of course, because it's fresh, you can maybe really remove the full clot, and you have more patency, at least a wider lumen.
Do you feel that it takes more time to use thromboaspiration than to go straight to a Rotarex, or no?
If it's fresh, no, it can be really fast.
Okay.
In the case that I showed yesterday, I had the aspiration times was 6 minutes.
That was it. What about you? What have you?
I use usually, like, for 80% of my cases, I use aspiration, and then use a non-aspiration basket type device through the aspiration device, and I'm done usually like an hour and a half most cases, and it's usually a mixture of fresh and chronic.
To be specific, you go in with a Bolt 7.
I go in with the bolts. So
The
for the
Penumbra
SFA,
Bolt 7 system, which is the
SFA,
smart one.
Yeah, for the SFA, I do a Penumbra Bolt 7. Usually, what I get is usually acute on chronic, or an embolus that then just creates fresh thrombus, and the Bolt 7 gets caught sometimes in that, and then when it gets that more organize stuff, then I bring out a pounce and then I just pounce it, and it's done.
So
Boom.
you do the pounce
through the Volt 7.
through the Bolt 7
Yeah.
to get into the distal part.
For the SFA and pop, yeah.
Yeah, like yesterday we had a live case with PK in New York, and he was opening this very long stent from the proximal SFA all the way to the TP trunk.
Yeah.
All stent.
Yeah.
All occluded. And he was doing it live. He's a crazy psycho. But he did penumbra, and then there was this part that just wouldn't work. And I said, like, hey, I think you should just, use a basket. And he was like, okay, well, we're I was like, no. Leave the 7 in place, and then put a basket through it.
Oh, so you told him to do what I told you to do?
Yeah, you told me to. Well, I've done what you told me to do, and it actually works. And so I didn't try to tell him to do it.
I'm glad I contributed something to Link.
Well, now you contributed to PK, because he then sent me a text and said, I'm going to do what you told me, but I'm not going to do it for the first time on a live case. I'm sorry. I said, it's okay. But do you have access to the pounce, some of these baskets to pull in, or no?
We had some from the neuro.
Okay.
Something like that. But
do you ever use them or no?
No.
There are a bunch coming out. Inari's coming out with one. There's some other company that we met at Beath that's coming out with one, and they all are kind of imitating pounce, I guess. But yeah, with those two, and as you can clear an SFA in an hour and a half.
So what about, let's switch it up. Let's say we're talking about clot in the below the knee vessels. Do you change your algorithm in a different way?
No, it always would be maybe a 6 if the 7
so you'd go to a 6 catheter.
Yeah,
okay.
Yeah, but if the 7 doesn't run down to the...
I think that's one thing to remember is if you think about Penumbra, where it came as a company, they started as a neuro company. And so their catheters are extremely atraumatic. So, if you have any hesitation about putting a 6, chances are this is a very soft catheter that you're not going to like screw up the vessel wall. I feel like,
unless it's diseased.
Well, but you have to be really, really rough to like screw up, because these catheters are extremely made soft precisely because that. So you can put them into you can put into the cerebral arteries without any problem a 6 French.
Yeah.
Very easily up there.
But usually those vessels don't have severe plaque.
Agree. But what about access? Do you consider changing your access? And if it's just like maybe distal pop or a TP trunk, do you go antegrade, or do you still go up and over and suck it out?
I do go always antegrade.
Always.
If I have, even for a superficial femoral artery, I do ultrasound guided puncture whenever is possible. And that is
antegrade?
the way that, antegrade is most of my choice, if possible. If at least I have a little space to stay in.
But what if it cuts right at the ostium with the SFA?
All the time, of course, when it's not possible, I go for an up and over. Yeah. But whenever I have the space in the common femoral artery to perform a puncture, maybe even in the beginning with the 11 centimeter sheath a little bit out.
Yeah.
Maybe just
so
half
if you
in.
have a thin enough patient, let's say they're thin, and you got 4 centimeters of common,
I go for
you're going to poke there, and if you have to, you leave part of the sheath out, and then you bring the penumbra, and then go blah, 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 blah into the SFA, and then once it clears up, then you can actually insert the sheath more into the SFA. Is that a very usual part of your algorithm?
Yeah,
okay.
That's what I do. Because nothing against up and over, but even for chronic, I don't use the up and over. Whenever it's possible, I always go antegrade. That is something that is really different, because there are not too many that like to go always antegrade.
But I'm 100% antegrade.
Perfect. Because
as much as I can. Very rare that I go up and over.
But most of the time they look at you, but why you choose pushability, trackability, and many reasons.
I for most of my cases do antegrade, but if the SFA is out, then I'll go up and over for at least for ALI for sure.
So what happens if you're trying with the penumbra 6, and maybe how these things sometimes you got to chase them, and you chase them and you chase them, and now it's like in the distal third or something like that. How do you escalate at that point? The 6 French doesn't get all the way in. You're having trouble. There's maybe something down there. What's your next tool
How do you mean that
for clot? Like we're
for
chasing
clot,
clot and maybe it's
it
distal and you
doesn't
can't
get out?
if you can't get the 6 French penumbra down or it doesn't come out appropriately, what at that point do you take?
Yeah, if it doesn't run down, it's because it's too old.
Okay.
So it's probably the thrombus. So there's something that I may be a mistake calculating up front. So it's weird that it doesn't go down if it's fresh. But of course, it can happen. Then it switch maybe to something of different, like a Rotarex. That is something that's very expensive.
Yeah, you put a Rotarex in a tibia?
Yeah, because then I suppose that it's something that is older than that.
I've never put a Rotarex in a
I-
tibial.
You can put Rotarex into it.
Oh.
For some weird reason, you're very afraid of the Rotarex.
Oh,
Have you been bitten by it? Have you
yes.
perforated?
Yes.
Oh.
No,
Yes.
it's absolutely
Who taught you?
not
You
on
did.
that.
You did.
Then I taught you what.
Yeah.
not wrong.
No, I'm afraid of distal embolization. I don't like to perform angioplasty in thrombus. That is something that because maybe you can get distal.
Yeah,
and
you
distal.
push stuff. Yeah.
Yeah, but the different if it's that maybe it's acute on chronic, and I remove everything with the 6. Then I go for classic, but that's because I'm convinced that it's chronic and no longer thrombus.
I had a really good experience, and I've told you this before. This is Lucas pushing me to use some of these new stuff that I wasn't using. This was a lady that came in with a very ischemic forefoot, and I found her to have a very friable AAA. And so I remember the first day I fixed the AAA, she was in severe pain. And then I changed and I put an antegrade sheath and everything was perfect, clean. It had just showered down whatever was in that sac. And you could see that the DP was essentially stopped in the mid DP and there was no flow to the foot. And so I got a wire and the wire actually went very nicely through like the arcuate. And so what I did was Pounds, this company Pounds from Sermonics, this catheter has a low profile catheter, which I don't think you had used that way. You just told me use this device, but you hadn't really used it in the pedal vessels. But I was able to put it is a 018 micro catheter. And so you float it all the way through the arcuate. And then you put these 2 baskets like the neuro baskets we were talking about. And so you deploy them both. And then you start just slowly pulling. And what I did is I had parked like a 65 or 45 antegrade sheath Terumo that I can open up in the back, in the popliteal.
Yeah.
And I actually put suction through the sheath. So I put I did the old fashioned Costa Rican sucker.
Okay.
So
keeping it old school. Good.
yeah.
Good
So
for
I
you.
did a suction from the 45 6 French sheath into the pop as I was pulling. And a lot of shit came out. And it was like a lot of white and also some fresh and old stuff that was probably in that sack. And this whole arch just came back. It was like magic. Like, I don't know that I could have done it because in the past, what I did for those is I would try to put a catheter in that didn't pull anything. I haven't tried putting a 6 penumbra all the way down there, but I bet you in that lady, I maybe could have, but she was pretty small vesseled. I don't know if it would have floated all the way down there.
2.1? Maybe.
And it would have been maybe hard, but it was an interesting thing
Do
to
you know
have.
what I did the other day? That I was like, oh shit, maybe I'll do this more. This lady had a first toe small dragon green, and then I do an angio, and she has like those really calcified lesions just past the ankle in the DP. And you put an ultrasound on it, and it's like pure white calcium. So I go from above, Astaro, couldn't get into the right place. Then I'm like, okay, I can see that there's outflow distally. So I puncture like right at the base of the toe, and I get it through, and then I get it through and through. And then an angioplasty, and there's thrombus. Like, I angioplasty, it's open, but I can see that there's moving thrombus there. I was like, okay, what the hell? So I went in and I put the smaller pounds it a couple times, got some clot, some calcium out, and had like a complete arch after that. I was like, oh, that's interesting.
Yeah, this Pounce low profile for these uber distal vessels, I think it could be a very interesting tool because I don't think that there's good tools for that.
Yeah.
So I like the idea, Antonella, of trying to put a 6 French, but if it doesn't go, then maybe wherever it is, let's say it gets to the distal ankle, but doesn't go into the DP, then you could actually put a microcatheter, put a pounce, and then turn on the machine, suck, and then pull into that.
Yeah.
Which is what I think. I think the combination of some of these things. I know there's that, Penumbra has that little thingy, but I don't
Oh
think
my God.
that does anything.
It'll choke you with
Do you
it.
use it? I don't-
No, I think it's not available in Europe.
Oh, really?
Just for US,
Well,
just for
they
US.
had this one little thing that was like kind of to this.
I know the
Yeah.
separator.
The
you mean.
separator,
I know
see.
the
Yeah.
separator. Yeah, sorry, I thought
It's
another
called-
one.
No. Do you use that a lot or no?
It's
You
called
don't.
it's called thrombus masturbation.
Okay. And on that note, listen, I want to do a time check. It's been about a good 45 minutes at 50, and I know you have a busy schedule here at Link, Antonella. This has been wonderful, and I really look forward to having more conversations with you.
It was a pleasure to be here. First time, and
Yeah.
it's so nice. And yes.
All right,
It's
then you're coming
nice.
back.
See, we have turned you into a
No,
believer.
you really helped to relax, and it was fine. It was really
See, we also
cool.
gave you tequila before we started. No, I'm
Yeah.
joking. But we have to sometime. A lot of times if this is in
But
the afternoon.
you're on the Don Julio at least.
Yeah, we like to
Yeah.
do some of them with wine or beer, and
Yeah.
if
Well,
we're in
I mean,
Mexico,
it's
we do
almost 3, so
tequila.
the beers are coming out soon.
At 3, yeah. So yesterday I tried to get beers in. I got scolded by the people that help. It's like not until 3. So after 3
After
in
3 is
Germany, we're
allowed.
allowed to have
Yeah, I
beers.
know.
Okay.
Yeah.
So if unfortunately next time we'll have you after 3.
Yeah.
Let's do that.
All right, thank you very much, Antonella.
Thank you very much,
Bye-bye.
Thank
Antonella.
you.
Ciao.
Pleasure. Thank you.